Welcome to the Congress Author Podcast Series, brought to you by the Cytokine Signaling Forum, where authors review their Congress posters and presentations on cytokine signaling and JAK inhibitors. This edition, recorded at ACR 2019 in Atlanta, focuses on Upadacitinib. The first two presentations focus on data from the Phase 3 SELECT trials. Professor Burmester will discuss 60-week data, but first we will hear from Professor Smolen.
This poster is about Upadacitinib as a monotherapy with results over 48 weeks. We already showed the results of 24 weeks before and showed that Upadacitinib monotherapy at 15 and 30 milligrams in patients who immediately switched from methotrexate to Upadacitinib was highly effective. The control there up to week 12 was continuation of methotrexate. So methotrexate continuation in methotrexate insufficient responders. What we show here is the extension into 48 weeks. Primary endpoint was at week 14. And the patients who were on methotrexate only were switched at that point in time also to either Upadacitinib 15 or 30 milligrams. And what we can see on the poster is that those patients who continued to use Upadacitinib after week 14 into week 48 maintained their overall response. Indeed, there was even an increase in ACR 70 and slightly in ACR 50 responders. We know that ACR 50 and ACR 70 responses take slightly longer than 3 months. ACR 20 almost reached a plateau at that point in time. So the efficacy was maintained. But those patients who were on placebo plus continuing methotrexate and were switched to Upadacitinib now within a short time came up to the ACR 20, 50, 70 levels that the patients who started with Upadacitinib had already reached. So that shows dually the efficacy of Upadacitinib. That also pertained to HAQ, to physical function. It also pertained to change in scores, such as pain and other scores. CDAI, for example, CDAI remission was attained in 20% at week 48 of Upadacitinib 15 milligram, and even more in patients using Upadacitinib at 30 milligrams. Now, with respect to adverse events, there was no major difference between the two doses for most of the adverse events, especially not for serious adverse events. However, for herpes zoster, there was a slightly higher level of herpes zoster in patients who used the higher dose. So overall, what these data show is that you can easily switch from methotrexate to monotherapy of Upadacitinib, which is approved at 15 milligrams daily, and that the efficacy is maintained, and it has an acceptable safety profile like other JAK inhibitors.
Hello, my name is Gerd Burmester, and I'm here at the ACR 2019 in the beautiful city of Atlanta. The title is Long-Term Safety and Efficacy of Upadacitinib in Patients with Rheumatoid Arthritis and an Inadequate Response to Conventional Synthetic DMARDs. We are presenting here the results at 60 weeks from the SELECT NEXT study. Actually, the first 3 months have been published recently in The Lancet, and the question was, how do these patients do after this initial shorter period, which was short because it was placebo-controlled, and for ethical reasons you cannot do this longer. What did we do? The patients were either in the placebo arm or in the Upadacitinib 50 milligram arm or the 30 milligram arm. The patients being on 15 or 30 stayed in the same arm. The patients on placebo either switched to 15 or 30. So now we have data for 60 weeks of patients being on either 15 or 30 milligrams of Upadacitinib. So let's have a look at the efficacy first, and what I think is quite remarkable, because normally we are used in this conventional synthetic DMARD inadequate population to the rule of ACR 20, 50, 70, 20, 40, 70, 20, 40, 60 rule, and the data are way above it, because ACR 20 response was above 80, ACR 50 above 60, ACR 70 close to 40 or even above. So these are remarkable efficacy parameters, and interestingly there was no difference between 30 and 15. So by doubling the dosage, we did not see additional activity. What was also nice, the placebo patients rapidly caught on to the original efficacy in those who had gotten the drug right away. So this was also true if you looked into the various measures of remission, even including the very stringent criteria like CDAI and the Boolean remission. And in the CDAI, it was above 30 that we saw remission in these patients. Obviously, very important question, what about the safety profile? Well, compared to the JAK program in general, we didn't see additional signals. Again, what popped up was the herpes zoster signal, which we know in JAK inhibition. But what's also evident was that there was a somewhat higher signal rate in the UPA 30 group compared to the UPA 15 group. And now we know that after the filing, UPA 15 has been approved. We don't apparently need the higher dosage, at least in rheumatoid arthritis, because we could see here in the SELECT NEXT study was exactly the same efficacy. So this is not bad news, because we can go with the 50 milligrams. 30 would have had more signals. It may be necessary in some other diseases that needs to be explored, but here we saw a safety profile with 15 that we know without any new signals.
The next two papers focus on safety data, with Professor Yamaoka comparing the safety of Upadacitinib in Japanese patients with global patients, and Professor Choi analysing cardiovascular events from the SELECT trials.
I'm Kuni Yamaoka from Kitazoto University in Japan. This is comparing safety in Japanese population and the rest of the global population. There's 6 trials, and we picked up 371 Japanese patients and compared it with the other global population. There are some difference in background, such as BMI. We Japanese have lower BMI and the other has higher BMI. Some differences, but to highlight is we had a little bit higher serious infection, higher zoster, a little bit less TB. The other, there's not really a big difference. If you look at the whole global population, there's not really a big difference compared to other JAK inhibitors. But with the Japanese population, there seemed to be a signal, but we think that it could be something that related to age. We had more older patients in our Japanese population, so that could be affecting. We don't really know the real reason we see a signal compared to the global population. One thing to explain about zoster is, like I said, the age, and we also have barely no patient that has been vaccinated, which is not the case for the other global population. There are 3 to 6% of the patient has been already vaccinated, which they have a very low risk. There's no difference in steroid use. So there seems to be a signal, but we're going to do some analysis on why we see this and figure out, which the patient has a higher risk.
I'm Ernest Choi. I'm Professor of Rheumatology from Cardiff University in the UK. At the ACR 2019, I presented the result of a pool analysis of major adverse cardiovascular event and venous thrombosis event from the phase 3 program of Upadacitinib, which is a recently approved JAK1 selective inhibitor for the treatment of rheumatoid arthritis. This analysis utilized 5 phase 3 clinical trials of Upadacitinib and looking at major adverse cardiovascular event, DVT or PE in the patient. And we compare the incidence rate in the Upadacitinib group with patients treated with either placebo, methotrexate, or adalimumab in this study. And overall, it shows that the incidence rate of major adverse cardiovascular event as well as venous thrombosis event are very similar across these treatment with no indication of a signal. In addition, there is no dose relationship between the event in the 15 or 30 milligram group. Many of the patients who have major adverse cardiovascular event or venous thrombosis event have at baseline recognizable risk factor such as hypertension, obesity, diabetes, which may have predisposed these patients to getting this adverse event already. So at the moment, based on clinical trial data, the Upadacitinib treatment does not seem to be associated with either major adverse cardiovascular event or venous thrombosis. Obviously, this needs to be correlated with real-world observational study and much bigger sample size in order to look at these associations.
In our final section, we have 2 presentations reviewing different clinical situations, with Professor Butch comparing mono with combination therapy, and Professor Fleischmann presenting data on switching from TNF inhibitors to Upadacitinib. And finally, Professor McInnes presents data on the mode of action of Upadacitinib.
I'm Professor Meyer Butch from the University of Manchester, having recently moved from University of Leeds, and I am going to provide a summary of one of the posters, number 511, at the American College of Rheumatology 2019 meeting, entitled A Comparative Analysis of Upadacitinib Monotherapy and Upadacitinib Combination Therapy for the Treatment of Rheumatoid from 2 phase 3 trials. So the pretext of this poster was really to build on increasing discussion and interest around the use of targeted therapies as monotherapy, as we have increasingly recognised that a sizable proportion of our patients on biologic DMARDs are treated in real life as monotherapy. Certainly in the background prior to the JAK inhibitors, the trial data on biologic drugs have certainly demonstrated that the combination with methotrexate is the optimal to improve significantly signs, symptoms and structural outcomes. Yet in reality, we realise that methotrexate intolerance and the inability to necessarily combine strategies using methotrexate isn't always possible. So within the Upadacitinib program of trials, there are 2 studies that have evaluated one combination therapy and secondly the monotherapy. So Select Next and Select Monotherapy were the 2 trials. Select Next looked at patients who'd failed previous conventional synthetic DMARDs and were randomized to either continuing background DMARD, Upadacitinib 15 milligrams or Upadacitinib 30 milligrams. And Select Monotherapy, so in Select Next they continued the background DMARD. In Select Monotherapy, these were methotrexate failure patients that were either randomized to methotrexate placebo or one of the 2 Upadacitinib doses as monotherapy. Now, each of these trials demonstrated significant benefits with Upadacitinib, but there was a remaining question as to whether there's a difference between Upadacitinib monotherapy or combination. And in the absence of a direct head-to-head study, an indirect analysis was undertaken, and that was the basis of this poster. So this was an indirect analysis comparing Select Next and Select Monotherapy. The The caveat is always that this is a post-hoc analysis. It's indirect, and so there has to be more caution and interpretation. Broadly, however, the populations were similar in terms of demographics, where recruitment was from, disease duration, disease activity, mean methotrexate dose. And so the analysis took the form of, in the select next study, only including patients who were on background methotrexate into this analysis. So there are about over 600 patients in the total trial, of which over 400 were on background methotrexate, and they were included in this analysis. And the patients from select monotherapy were all included. And the primary outcomes were ACR 20 response and DAS 28 CRP of less than or equal to 3.2, so low disease activity state, at week 12 and 14 time points. And the different time points are to reflect the two different trials that had slightly different time points for their primary outcomes. The analysis was indirect. It did a controlled group analysis for monotherapy versus combination, and it adjusted for factors that we recognize are relevant, including serological status, baseline disease activity, smoking status, etc. In essence, what was observed, that if we look at the primary analysis, so ACR 20 response and the DAS 28 less than or equal to 3.2, there were no significant differences between upadacitinib monotherapy versus combination. Numerically, it appeared to be higher in monotherapy. Similarly, when there were analyses then looking at the more high hurdle endpoints, so ACR 50-70 response, and then also including CDAI and other outcome measures, there were no significant differences between the two strategies. Numerically, in almost all those outcomes, it appeared that monotherapy had higher response rates or was achieving better outcomes, but I would caution any interpretation on that. This was post-hoc indirect, so that all that I would interpret is that essentially the two strategies appear to be comparable, consolidating what the individual trial data is suggesting. Certainly wouldn't be able to extrapolate any more from that. This is important because, as I alluded to at the very beginning, monotherapy has become increasingly relevant, partly because the patient-physician expectations have changed. Our threshold for burden of treatment is now becoming relevant, whereas previously our sole focus was only achieving good efficacy outcomes. And now patients are voicing concern, understandably, in terms of burden of treatments, and methotrexate becomes relevant here. Also, we're treating an aging population. Demographics are changing. Comorbidity, multimorbidity, and the whole issue of polypharmacy is increasingly recognized. So what these data suggest is, in populations, particularly where methotrexate may not be appropriate, may not be feasible, upadacitinib appears to provide a treatment option where we're not compromising and jeopardizing efficacy for the sake of maintaining a monotherapy strategy. And I think clearly, in terms of future outcomes and post-marketing surveillance and real-life data, will be incredibly important. But I think this has the ability to influence clinical practice, as we're seeing in the area of lots of other therapeutic strategies as well.
I'm Morrie Flash from the University of Texas Southwestern Medical School in Dallas. We're going to talk about abstract 2907 from ACR 2019. And what this abstract was about was the clinical and functional outcomes in patients with active rheumatoid arthritis who were switching between a JAK1 selector, upadacitinib, and adalimumab if there was an insufficient response. So this is an analysis from the Select Compare study, which has been previously published. And in Select Compare, with background methotrexate and incomplete response, we looked at upadacitinib 15 milligrams once a day, or adalimumab 40 milligrams every other week, both plus background methotrexate. And we wanted to see whether or not there was a difference between adalimumab and methotrexate. So a ranked secondary endpoint was the ACR 50 response, change in HAQ-DI, and change in pain between upadacitinib plus methotrexate and adalimumab plus methotrexate. And this was a positive study. So the study was done actually to see whether the 15 milligram was better than placebo, which it was in this trial, and whether or not there was superiority of upadacitinib versus adalimumab by those endpoints, which it was. And in this trial, every secondary endpoint as well as both primary endpoints were met. Which is nice. But what was really, really interesting about the design of the trial and what was unique was actually the switch. So at week 14 and week 18 and week 22, if the patient had no response, defined by a less than 20% improvement in tender and swollen joints, with either upadacitinib or with adalimumab, they were switched to the alternative agent, and they were immediately switched. There was no washout. And then, so these are the non-responders. And then at week 26, any patient who didn't achieve CDAI low disease activity, so CDAI of less than or equal to 10, with upadacitinib was switched to adalimumab, and patients who didn't achieve with adalimumab was switched to upadacitinib. So this switch, again, was without a washout. And it was very, very interesting because we've seen studies where patients have failed an anti-TNF such as adalimumab, switched to a JAK, and the JAK works, but there's been no study which has shown that a patient who fails a JAK then is switched to a TNF, and the TNF works. This is the first study that's done that. So the results of this study were quite interesting. In terms of the patients who had no response, it turned out that if you failed adalimumab, you could respond to upadacitinib. If you failed upadacitinib, you could respond to adalimumab. Numerically, more patients responded to upadacitinib, but this trial really was not powered to tell you whether or not that was a statistically significant difference. So all we would say is, fail one, you could respond to the other. Nice results. Secondly, and I think actually as important, were the patients who achieved did not achieve a CDAI of less than or equal to 10, low disease activity. They could have been 66% better. They could have started with a CDAI of 45, come down to 15, and still, because they didn't achieve low disease activity, they would have been switched to the alternative agent. So these are the patients that you see in the clinic where you think they've done fine because they've had a really good response, but it isn't to target. And then the question is, what if you switch? Well, in this study, it turned out, again, there were actually better responses in the patients who had the incomplete response to upadacitinib switching to adalimumab, or adalimumab switching to upadacitinib, with 50-60% of patients achieving an ACR 50. So there were two main points, actually three main points. One, these are immediate switches. We didn't see a safety signal. We didn't see a signal in terms of infection or any safety signal. You don't have to wait. You can do the immediate switch, fail adalimumab, start upadacitinib the next day. If you fail upadacitinib, you can start adalimumab the next day. The second is that if you don't respond to one, you could respond to the other. And if you don't respond to a JAK, you could respond to a TNF. And there are people who feel, I'm one of them actually, that given equal access, I would probably start with the JAK over a TNF. And then if the patient fails the JAK, I would go to the TNF. And then the third is that, yes, a patient has no response, could respond to the other, but a patient has a response, a clinically significant response, but still isn't at target, still isn't a goal. There is a rationale to switch them to the alternate agent because they could do better. So we think that this study actually was well designed to show these three endpoints, and that it was quite successful in doing that. Thank you.
Oh, hi, I'm McInnes. I'm the Professor of Medicine, University of Glasgow, and I'm here at the ACR in Atlanta. So this is a poster in which we've taken whole blood from 200 patients who received Upadacitinib, 15 milligrams, and we've analysed that whole blood for a gene expression profile, so that's RNA up or down regulated over week 2, week 4 and week 12. Key findings are that there are changes that we predict in circulating leukocyte populations, mainly B cells, to some extent neutrophils, eosinophils, number one. Number two, when you then apply an ingenuity pathway analysis to that, we see probably predictable downregulation of the expression of a whole range of inflammatory cytokines, upregulation of ACR2, which is a master regulator of chemokine receptor biology, and of the IL-1 negative regulator IL-1RN. And when we look at the impact of that in the cellular level, we see really broad pan-leukocyte effects. The immunological impact, therefore, is general immune homeostasis. Very difficult to then refer that back to any one individual JAK cell activity.
Thank you for listening to this edition of Congress Author Podcasts. Make sure to subscribe to the CSF podcast channel on Apple Podcasts, SoundCloud, or wherever you get your podcasts from, so you don't miss out on more ACR 2019 content coming soon. If you found this informative, why not listen to our other podcasts, which include author interviews and a monthly review of the latest cytokine signalling papers, hosted by the CSF Steering Committee Chair, Professor McInnes. You can also visit cytokinesignaling.com for access to a wide range of free educational resources, including monthly slide summaries of the latest papers, accredited CME courses, and Congress highlights.